Thank you, Dr. Kuchner. So for our final speaker tonight, we have Jennifer Crossdale. Jennifer is a licensed clinical social worker with a certification in hospice and palliative care. She has worked in the outpatient and inpatient setting for the past 10 years for hospice and palliative. Currently, she works at Norton Healthcare in the inpatient palliative care department, and she works closely with patients and families who are navigating illness and end of life. Please join me in welcoming Jennifer Crossdale.
Thank you. So I think at the foundation of everything we've heard so far, right, we can all agree that what we're hearing is the practice of connection, compassion, communication is where we need to be when we're talking with families and having these serious discussions. I would argue too that we also, regardless of our discipline, can provide something to a family, regardless if we're a physician, chaplain, social worker, or nurse. We all have a part to play there, and we all have meaningful things that we can contribute. So what I'd like to go through first, this is a mnemonic, another one, called SPIKES. This is a typical goals of care conversation that I'm sure a few of you may be familiar with. And I want to talk about this because we can pick it apart. It's not always in this logical order when we talk with families, especially if our role is not necessarily, belonging in a goals of care conversation with the family. Maybe it's coming in for a moment as a chaplain to provide support to family. But let's pick apart each part of these to see how we can provide that support to families. So the first is S for spikes, setting rather. So first and foremost, when we go to talk to a family, okay, we want to make sure, one, we're prepared. We're walking into the room, we know the latest and greatest of what's happening with that family. We know the latest tests, exam, blood work, because you're going to be asked those questions. Not necessarily me, but maybe the physician, okay? We want to make sure that the key players are there. That includes the patient. And I want to encourage that because a lot of times we might get pulled separately from family to talk about a patient separate. You have to be very careful doing that because that's called collusion. And we don't want to do that. If the patient is able to participate, we want to make sure we're including them. A private space. This isn't always doable, right? Sometimes it's an ICU room. Sometimes it's in an exam room. If you have a green space, if you have a conference room, great, but make your space available for what it is. So limit distraction, turn off the patient's TV, make sure your phone is off. Ask other people, if you don't need to be here, maybe it's time to go get a drink or something. That's okay. Provide yourself the time. I think we've heard that a few times tonight. These conversations take time. It's not always 20 minutes, it's not always 2 days. Sometimes it can go on for a long time because we are creating a relationship. We are providing space for that patient or family to develop trust and rapport so that we can help them and guide them through these really difficult decisions. Also, when we're in those rooms, we want to make sure we're eye level, right? Because that's how we are fostering collaboration. We want to sit down with each patient. If other people are in the room or standing, let's find them a chair. We're going to be there for a while more than likely. So get comfortable. If you know you're going to be introducing a new diagnosis or perhaps a new service to this patient or family, bring some tangibles with you. Bring a pamphlet, something to leave them with so that they can rely on, some education once you leave that room. Most importantly about all of this, I would say, is that you can't expect perfection from yourself because these conversations are exactly what this is titled. It's difficult. It is difficult for the patient. It's difficult for the family. It's difficult for us as professionals to sit there and say these really hard things to people. It takes a lot of time and a lot of practice to get comfortable having these discussions with folks. So it's okay to mess up. As long as you're showing up and doing your best, people know that. The P stands for perception. So this is a part in a conversation where we might say, tell me what you know. We're inviting participation. So questions you might ask here. What is your understanding so far? What have the doctors told you? Tell me more about that. We don't ever want to assume that we think the patient understands what's happening, that the family understands what's happening. You need to get a clear idea of what they understand, okay? Next, we're going to talk about invitation, the I. So this is where, again, we ask for permission. We're inviting more information. You might say things like, has anyone told you what this means? I'd like to explain what this means for your dad, for your mom. And then I think by doing that as well, you're inviting that collaborative relationship, but you're also providing some control in a situation where many people feel like they have zero control. Next, the K stands for knowledge. So right in this scenario here, we are just providing facts, okay? We're sharing what has changed, okay? So again, like you've already heard tonight, we want to give a bit of a warning shot before we go in and say this terrible thing that might have changed, the bad news. So we might say something like, I wish I could say that chemo always works. I wish that were true, but I have some bad news. I think we're in a different place. The CT scan shows the cancer's gotten worse. And then I want to pause. This is where we're giving space for that thing we just said that is going to sit very heavy with anyone to hear that. Those are those times that are really hard for anyone to allow room for silence. That is such a hard thing to do when you're in those moments because you want to fill the space. But this is a time where people are processing, and it's often a really good connection point to just sit and let a family feel the sadness, feel the pain, feel the shock. And it's okay to sit there in silence for a few minutes. Next, because you've received permission from them, we want to avoid using medical jargon, but also provide our medical perspective, okay, on what's actually happening. So you give your spill, your take on what's happening, okay, but in layman terms, in words that people understand. We want to avoid all of those acronyms and, machines and names and things like that, because more than not, people don't know what those things are. The E in spike stands for empathize. And I think for me, this is, as a social worker, of course, this is where a lot of the connection comes from. So here, you want to, you just said this terrible news. Things have changed. This is what's happening now. Your first response that you might expect is going to be an emotion, shocker, right? So that's why we allow for that pause there. It's okay to sit with that expression or that emotion being expressed at that time. Give everyone some time to kind of collect themselves. Again, allow for some silence. We don't want to interrupt. Don't immediately reach for the tissues. You don't have to do that. It's our natural instinct to try to do that, but you don't have to. Avoid saying in that silent moment, I know statement. I know this is hard. I know how you feel because maybe you've been through something similar, but I can guarantee you do not know how anyone feels. This is their own personal story. So avoid using statements like that. You can say things like, I can see this is not what you were hoping for. I can see that you're upset. I see that you're angry. And naming that, like we've heard, helps to de-escalate some of that reaction because people feel hurt. They say, you see me, you hear me. Yeah, this is really hard. This is also a great place in a conversation to just pause for a minute and try to learn a little bit about the patient that you're taking care of outside of the illness. So tell me a little bit about Dad before he got sick. What's he like? Tell me kind of what kind of person he is. What does he enjoy doing? This is going to help us in the next part of our conversation. But it also helps that person who you might be sitting with to kind of remember their loved one or remember the things that they enjoy doing before all of these things started. Okay. It brings that back to that personal connection. So lastly, in Spikes, we have strategize. So this is where we're coming up with a plan as a team, as a collaborative type of communication with a family or a patient. So again, we ask, would you like some recommendations? Again, this gives them control to them in an environment they might feel they have zero control. We want to offer options, not opinions. Sometimes I think patients ask me, at least, what would you do, right? If this was your sister, your mom. And there's a space for that, but I think you do have to put a little asterisk by that and say, but this is my story, this is yours, and it's okay, whichever road you choose, because you know your person best, you know how you feel. Also, don't want to dismiss any concerns because, again, a lot of the new information or just learning more about someone's medical trajectory, it can be really confusing, okay? And so some people might have concerns that you might not think they even have, but they can be something underlying that they're really worried about. Like, well, if we take away the ventilator, what is that going to look like? Are they going to suffer? Are they going to suffocate? No, we know that that's not actually how that works. There are lots of ways that we can keep someone from suffering in those final hours, but they might think that that's the only way. So we want to acknowledge their concern. I think too here, don't offer false hope. This is a very difficult thing not to do because, especially as medical professionals, it's our role, right, to fix, to make better, to heal. But we all know too that that's not always possible. So when you give that false hope or unrealistic expectations, it doesn't help the situation for anyone. Again, we go back to those moments of pausing and allowing for space for people to feel their emotions. And it's difficult to sit there when people are sad and when they're angry and upset. We don't have to respond in a way that is trying to fix that. We can sit with that. I would also say too that along those lines, working with families, a lot of what I hear over and over again, it's that, these conversations that we have with families or the patient, it's not that we were there to fix anything. It's not that we were there to, come up with the answers. It's that we were there, right? That we provided the space for someone to feel in the moment what was happening with their emotion, what's happening with this change in their life. And for patients, I feel like that's the most powerful thing that we can provide is that space, those opportunities. Lastly, I would say don't expect immediate decisions. We all know these things take a lot of time, and often we don't get the answers that we're hoping for, right? But a lot of times we're planting seeds. The trajectory of someone's illness, these difficult conversations, we can be at the beginning or at the very end of someone's decision-making process, and sometimes we're just planting a few seeds here and there. So over time, they might recall these conversations that we've had and come back to a point where they can say, hey, I remember when she said this might be a problem, or maybe I do need to think about Dad, in whichever way. So a few of these resources, if you're interested in trying to build your skills for difficult conversations, regardless again of your discipline, I would recommend these two organizations, vitaltalk.org, catseat.org. They have a lot of great resources that you can use to practice and videos. Vital Talk also has an app that you can put on your phone. So if you have, a few minutes before you go into a room that you're a little worried about, you can look over it, kind of get a quick, booster about what you're going to talk about or how you might go about saying things. Great resources there. What questions do you guys have for me?
I just want to, it's not really a question, but just an observation. I accompany a lot of people as a faith community nurse. And the thing that seems to confuse people, family, more than anything, is that they are getting mixed messages from every different discipline of doctor that comes in.
Yeah.
And one of them will tell them something that will completely contradict another one. And they, it's like they're not talking to each other, and it just leads to a lot of confusion to families.
Yeah. So a lot of time we hear that a lot. So a lot of times in those moments, what I encourage families to do is say, when this doctor comes in, you might consider asking, what does this mean? What does this mean for Dad? If we do this, what does that lead to? So in just kind of planting some ideas for questions that might encourage them to dig a little bit deeper so that we can all be on the same page. Ideally, we should all be on the same page regardless before we walk into that room, right? But it doesn't work like that in practice, unfortunately, the majority of the time.